Thank you for tuning in today to hear my pitch on communication in post-operative patients at Dartmouth-Hitchcock Medical Center Plastic Surgery, specifically surrounding nurse-only visits. Today on the agenda, we're going to talk about the communication that's going on post-operatively, meaning when the patient gets discharged after they have a surgery, when they go home with instructions, and what that entails for the patient communication-wise, and what that entails for the person taking care of them, whether it be a nurse, caregiver, VNA, or an APRN, which is an advanced practical nurse. So on the agenda is no written orders, no follow-up, multiple calls, and wasted time. And then we'll move into a new solution, and a solution for this is just to develop a new communication protocol that everyone follows by, a new standard of care at Dartmouth in plastic surgery. And we'll sum that up with talking about the budget for this program and a conclusion. Then we'll have some questions and answers. So recently we found that when patient gets discharged from the hospital and they come in for a nurse-only visit, they are having specific orders written in their discharge instructions. This can cause chaos for everybody. When there's no written orders, there's potential for patient safety. According to a case study, found specific areas of potential error involving physician-patient communication. A more accurate assessment of errors prevent events in primary care is necessary to develop successful interventions to improve patient safety. So patients under your care, you're doing surgery. When they leave the hospital, they expect to have the correct discharge instructions. This is important because it helps them do what they need to do at home to prepare themselves. And it also helps the nurse know exactly a better way to care for them when they come in to see them for a post-operative visit. To go along with that post-operative visit, sometimes we're missing post-operative visits. So sometimes the nurse will see the patient after surgery and they haven't seen the doctor yet, but the nurse doesn't know when they need to follow up because there's no order written in there. There's no indication of when the patient would like to come back and be seen, or when the doctor would like them to come back and be seen. And this is another potential setup for harm, because we could be missing a key step in their healing process for the post-operative plan. So Dietman and Gortza found that failure to keep appointments potentially affects the patient's health, disrupts the healthcare delivery system, and contributes to poor utilization resources. Further understanding of reasons patients are unable to keep appointments can be useful in developing policies to address unmet patient needs and effective delivery of healthcare services. So having a follow-up is important. Not having the order in the system also creates multiple calls. These calls can be most likely tuned into the operating room. So if physician's operating and you don't have an answer, you have to call in there to get the correct order in order to continue care for that patient. If a patient comes in as a nurse-only visit, needs to get sutures removed, there's not an order in the post-operative plan, you need to call the doctor, interrupt him during his surgery, and ask that question. More likely than not, you're not only interrupting the doctor, you're interrupting the whole team in there. The circulating nurse, the med-surg nurse, setting stuff on the table. But you're being disrespectful also to the patient. The patient doesn't know you're calling in there because they're asleep, but don't you think that if you were having the surgery, you probably want your doctor to have no interruptions, and you would want his undivided attention. So according to a study in the Journal of Surgical Research, a mean intraoperative duration of operation, meaning how long a doctor operates on average, is an hour and 23 minutes. During the 803 cases that they observed interoperative interruptions, disruptions, and events were observed. Most frequent were people entering and exiting, or telephones or beepers. On an average, OR teams were interrupted 9.82 times per hour in the operating room. That's a lot to be interrupted, especially if you're doing a big surgery under a microscope, or you're trying to figure out how you're going to piece this person's skin back together, or if it's a trauma patient. There's no need for any interruptions when there's a perfect solution. Just write the order down. Write the order down after discharge. Come up with a plan before you go into the operating room. Tweak it when you get out to see, if you need to add anything depending on how that surgery went. All of this is important to keep the patient safe. When calling into the operating room and you have a patient in the room for a nurse-only visit, you're wasting the time of the nurse and you're wasting the time of the patient trying to find these answers that could simply just be already written on a piece of paper. It's like when you make your lunch in the morning. If you just prepare it the night before, you can grab it and go. You don't have to waste the time in the morning extra to make a sandwich and to build your lunch from scratch. You can already grab it and go. Same thing with the discharge instructions. Write them out clear, concise, the day after surgery or right after the patient gets discharged, and then there'll be no holes and no running around to find the doctor, which is less wasted time. According to Lacey Palmer, Rudder, and Lovejoy, waiting was one way to show patients disrespect. The patients get to wait at appointment time. They wait in the waiting room. They wait in the exam room. It's a lot of waiting for them, and they end up feeling disrespected. Part of it may be just that there's just so many appointments, they feel like it's like an assembly line. We just set them up one right after another. And they feel like, they're just waiting around, and we're not giving them the answers that they came here for. And some patients travel a long distance, so I feel that it's a disservice to them if we're unable to give them the correct information needed to give them the best quality of care for their follow-up. This next slide talks about the solution. And the solution would be to implement a new communication protocol. In doing this, we can improve the quality of care by collaborative teamwork. Also, we'll promote patient trust by continuity and consistency in care management. If we all know what we're doing and we're consistent with it, the patients are going to trust that we're giving them the best care that we can give them. Encourages patient safety when there are no open communication loopholes and they're all closed and we all know what's going on, and ensures that patient safety is number one in our lives. It will increase patient satisfaction. So there's no break in communication. The patient's going to be satisfied because we're not going to have to stop. We're not going to have to stop to find the answer to their questions. We're going to know exactly what they're in for, exactly what we're going to do for them, exactly when they're going to return to see the doctor. And in hopes of this new protocol, it also is hopeful that, it decrease the cost, deaths, and injuries caused by communication failures. This slide is communication is the key. They pretty much did a global survey with nurses, and 98% of them agree that, communication with patient is number one. And then on the side here is a breakdown of different things that people thought were important with communication, or problems that happen when we don't have good communication. This next slide talks about the 7 C's of communication. Any communication starts with a good foundation and a good knowledge of what or how you can present yourself better, or communicate better to each other. And these 7 C's, I feel, break this down very good with it. So here it is right here. Content, continuity and consistency, clarity, context, channels, credibility, and capability. Next slide right here talks about failed communication consequences. There are 12 billion wasted annually on communication inefficiencies. 12 billion. That is a lot of money that could be used elsewhere. Also 1.5 million a year in fines on communication errors. And then there are 70% of accidental deaths and serious injuries in hospitals linked to miscommunication. That is a high number that hopefully with this new protocol in place, we can help decrease it a little bit, and maybe people will follow. So with any part of communicating, I thought that it's important to lay down the basics of the foundation. And so the basics of communicating is to have it be timely, clear, concise, organized, legible, and to reevaluate as frequently as required for patient condition changes. Meaning, if you have a patient that you did surgery on Monday and you wrote a post-operative orders out for them and they stayed over in the hospital 2 nights, and in those 2 nights things have changed, you need to go back and fix those orders and write them correctly so we know what the updates are and the changes to this patient's care. So the budget for my implement of new communication protocol total is $99,405. $55,000 of that would be contributed to a new employee. That would be a computer technician / EDH specialist. We are a hospital that uses electronic medical records, and so we would need a specialist to help us out with that and to implement a new smart phrase or new smart phrases that we can just use in discharge instructions. So if we just write like .abspla, then a fill in the blank sheet would come up and we'd have the basic information that we need, and we would just need to fill out the pertinent information for the patient. So it would make it a little bit easier for the doctors and the residents, and it would be consistent, but you would fill in the information only pertaining to what the patient needs at that time. $25,000 would be on the project manager, and they would work half-time. And then $12,405 would be material, like laptops, notebooks, pens, also communication programs that people can watch and help us with the trainings. The trainings overall with staff are going to cost like $5,000. And then $2,000 are for scheduling and chart scanning, and this is going to help us know how many patients we had in the last month that didn't have the correct orders, or the orders weren't written clearly, or did not have the correct follow-up in there. And that's going to be a big part of figuring out whether we were successful with this new communication or not, is going back and seeing what kind of numbers we had before we implemented this, and then going back again and seeing what kind of numbers we have after and what needs to be adjusted in order to move forward with this. So to conclude, this new communication protocol overall would bring the team together collaboratively. It would be less room for error, best quality of care for a patient, and better staff and patient satisfaction. Because you have communication overall in practice, and it's overall running smoothly. Your morale is going to be up between people, because they're going to be confident and feel good about giving the patient the best care that they can give, and in return the patient's going to turn around and score highly for you on the patient satisfaction score, because they're going to be satisfied with what kind of care you're giving them. And they're going to trust you about it. So that's it for my pitch on communication for post-op visits at Dartmouth Hitchcock Medical Center Plastic Surgery. Any questions?